how do we mount the maxillary cast onto the articulator in the same relationship that it is in the patient's mouth? So again, remember, it's important for us to mount that cast in relation to the hinge on this articulator the same way as it is in the patient's mouth, because we want the correct arc of movement as we're designing our crown in the lab on this articulator. So the question is, well, how do we get to that point, right? So you'll see here, this is our condyle. It represents our condyle. So if you look at your articulators, you got a big round circle in this corner here, right? If you guys all have your articulators. So that represents your condyle, right? It's a ball in a socket. Okay. So that yellow dot, we'll consider that the condyle. And there's a certain distance from the condyle to the teeth. Let me use a mouse in case anybody watches this later. Right? So there's this distance here. And on the articulator, we want to put the maxillary cast in the same position such that that red line is the same distance as it is in the mouth. Right? So maybe what we'll do is we'll first watch a little video on how to take a face bow, and then we'll talk a little bit more about kind of all the information that it gives us. Okay, so with that face bow, you can see we've captured the distance from the hinge axis to the incisal edge. You can think of it that way, right? From the frontal plane, you can see, okay, from the condyles to, let's pick the midline, right? We'll have that orientation or that information captured. So let's say your patient has, their midline is deviated 5 millimeters to the right side, right, from their facial. If you look in between the two condyles, you drew a line in between the two condyles, we'll say their midline is 5 millimeters to the right side. When you use a face bow, you'll have recorded that information in this face bow record, and then when you put it on the articulator, you would anticipate that that maxillary cast is also 5 millimeters from the center of that, the articulator, basically. Okay, so whatever is reflected in the patient's mouth, in terms from the frontal plane in terms of a lateral direction, you have captured that information as well. Okay. All right. So similarly, if everything's dead center, then you anticipate that the cast would be dead center as well. All right. So one of the things we got to kind of define is this Frankfurt horizontal plane. So we often refer to this. They talk about a standard anatomical position. So all your textbooks or your drawings in anatomy, they have some human being just standing upright, right? And then the question is, well, how do you know how far they should tilt their head for their kind of that standard position? Well, they pick 2 points, the orbitale, okay, and then your external auditory meatus. So they draw a line between those 2 points, and then those 2 points make up a line, and then we're going to assume that that line is relatively parallel to the floor. Okay, so we're going to say that that is parallel to our horizon. So now we have a standard plane that we know how to orient our patient, and that becomes sort of our reference plane. So the Frankfurt horizontal plane serves as our marker for the horizon, basically. Think of it that way. Okay? So the line that is parallel to the floor. So we have this anatomical landmark called the nasion. So think of it, that point kind of just above the bridge of the nose. Okay? And you can see in your face bow, you have this little curved kind of area here. And this fits nicely right in that curve there. Okay? So this instrument, the face bow, has a little feature that can help us position this articulator in relation to the nasion. Okay? And we'll say the nasion, on average, so some people have done these studies, they'll say it's about 23 millimeters from this Frankfurt horizontal. So we've kind of accepted this assumption, right? The nasion is just a little bit above the Frankfurt horizontal. So this point acts as our third point of reference. If you think about a tripod, right, you need that third point to really triangulate something in 3 dimensions, sort of like GPS, right? So this acts as our third point of reference that helps us orient our casts in relation to this horizon. So imagine I'm standing in my standard anatomical position where the line between my external auditory meatus and orbital is parallel to the floor, right? And if you're looking, if you can pretend you have kind of X-ray vision or you can see through my soft tissue, you'll see my occlusal plane of my maxillary teeth, right? So usually our maxillary occlusal plane isn't perfectly parallel to the floor. It's got some slope to it. So from the side view, what do we call that curve? Curve of Spee, right? And then from the frontal plane, we call that the curve of Wilson. So we have a curve of Spee, and let's say we want to kind of measure that angle, right? So it kind of matters if I'm standing this way versus this way versus this way, if you're just kind of, using the horizon as one line out of that angle. But if every time we can line it up so that my head position is parallel to the floor or parallel to this Frankfurt horizontal plane, then every time I make that measurement, it'll be consistent. So this is why the third point of reference is important, because it orients everything to this Frankfurt horizontal plane. So every time you make a measurement, or even between patients or visits, we're always using the horizon or the floor or the Frankfurt horizontal as our reference plane. Okay? Yes? No. This is 2 points make a line. So we pick these 2 points. So this is just designating our Frankfurt horizontal plane. So if you want to think of it, the third point, we're going to call this our third point of reference. The other parts of our tripod are going to be the external auditory meatus, which kind of simulates our condyle. And then really the teeth, we'll kind of group that as another point. So if you think about the face build from the video, right, we have 3 things touching the patient. So the part that goes in the ear, the part that goes on the teeth, and then the third point on the nasion. So that forms our tripod. And we need a tripod in order to orient something in 3 dimensions. That's why your GPS needs to triangulate. Yes?
So when you took the face bowl out, I noticed this part was adjusted.
Yeah. So
how do you know where that goes?
So the idea is that this part goes back and forth, obviously because it's got to clear the nose. And then once you bring it up to the right level, this will actually touch here. So once you've locked, remember the screws that are down here? Once you've locked that position in, this is no longer consequential. It's just, for the time being, it helps you orient. Because if you think about it, without that third point of reference, this part of the face bow can go up and down. It can rotate. So the question is, well, how do I know, should I take it here? Should I take it here? Should I take it here? Right? So this standardizes it by saying, okay, there's an average distance from this plane to the nasion. Every time, let's have this sit in the nasion so I know it's repeatable and it'll be kind of consistent between patient and patient and appointment to appointment and so on and so forth. Okay? So once you've captured and locked that bottom component, these 2 bottom screws, then you've kind of done your job. Okay? And of course, this you have to unscrew these because you got to get it out of the patient's ear. So again, this is loosened too. This is loosened. All that, you no longer need. Okay? Okay, so you can think of this line here, part of your face bow. We want to try to orient that according to the horizon. So, and on your articulator, obviously this is parallel. The top member of your articulator is parallel to the floor. Think of it that way. So really the story is if you got a third point of reference, it doesn't matter if the patient's standing up and you do the face bow, laying down, they can be upside down even, right? You're able to capture that in relation to the Frankfurt horizontal plane. So that's the point of that slide. Okay. All right, what's next? So you can see we'll put the face bow onto the articulator, and that's kind of how it fits together, exactly so how I have it here. The top member will hit this little metal plate, and then you can imagine putting a cast onto this articulator, or onto your bite fork where you made the bite record, and then you fill the rest of that with plaster, like we've done so here. Okay? The purpose of the face bow is to allow us to position the maxillary cast onto the articulator in relation to the patient's hinge axis in all three dimensions. So this is sort of the textbook definition. All right, so let's move on. What is condylar inclination? So if we look at our condyle, right, it's a ball in a socket. So not only does the condyle rotate, but it can translate, right? So translate means it moves from that hinge axis position. So as it translates, that ball, what guides that ball in terms of what direction it should go in? So what is this sort of anatomical? AE is our articular eminence, right? So the path of that condyle is going to follow kind of the slope of that articular eminence, right? So everybody has a little different slope to it. So for two things to be an angle, you got to have two lines. One of the lines we're going to pick is the Frankfurt horizontal. Okay. The other line is going to be the slope of that eminence. So if you have your cast on your articulator, and hopefully you have enough, is there like a group of three that doesn't have one that they can share? So once you guys all pick up your articulator, okay, and you guys can share, do you guys need one? This is what you're going to do. The latch in the back, if you unhook that, this allows you to slide your lower jaw forward, right? Really, you're moving the top member forward, but it's simulating a protrusive movement. Right? So your lower teeth are sliding forward. So everybody do that. So the latch in the very back here. So is everybody able to unlatch theirs and slide theirs forward? Okay. All right. So with the teeth in a close to edge position, what do you notice about the teeth? Let's pick your second molar. There's some space there, right? Does everybody see space in protrusive? So what you're going to do is loosen the top black knob. So you just pick a side, whatever side, and then let's set that to 0. So there's a little knob there. Set that to 0. Here, let me walk around a little bit. Okay, so top, big rubber knob in the back. So pick one side, and then the metal piece right next to it has, if you look at the side, has some angles or numbers on it. You guys with me? You see the numbers on the side? Yeah. Okay, so set that to 0, okay, in protrusive. So you're in a protrusive position, set it to 0, and then look at how much space you have between the teeth. It's too tight. All right, so now set it to 60 and see how much space you have at 60. So what do you guys observe? Ooh. Yeah, this is fine. You just hold it forward and then toggle it back and forth. Yeah. Okay, so you're going to turn the little knob. What do you guys notice about the space between the second molars? So as you go from 0 to 60, what do you notice about the space in the second molar? So the space increases, right? So that kind of makes sense because at 60, the slope is really steep, and as you go forward, your condyle needs to go down pretty quickly. And
60s would be like the articular eminence slope? Is that what that
yeah,
is?
yeah. So that number on the side represents our condylar inclination, which is the angle between our Frankfurt horizontal and then the slope that your condyle travels down. So that represents basically the slope that's in your head in there. The articular eminence, basically. Okay? So you can see if somebody is at 60 and they slide their teeth forward in protrusion, that space in the back is going to be really large. Whereas somebody with a flat condylar inclination, you're not going to have as much space in the posterior. So you can see the effect of condylar inclination on the disclusion of posterior teeth. Right? So if we were to ask the question, okay, how does the condylar inclination affect the space between posterior teeth? You would say as your inclination increases, the space also increases. And you can think of it as you condyle travels forward, right? It's a steeper slope, so it's got to move down more quickly, and thus you're going to have more space. So hopefully that part is clear to us. So again, our mandible has the ability to translate. So again, this is why it can be important to mount the cast in the correct anatomical position, right, relating the cast three-dimensionally to that hinge axis, because in our movement is influenced by kind of where we are in relation to the hinge. Okay, so the mandibular movement of the articulator closely simulates the movement of the mouth only if a face of record is made. Question?
How would we know?
How would we know the individual patient's condylar inclination? Great question. We'll get to that now. How do we determine the condylar guidance of a patient? Right? That's the question of the day. Okay, so this is a cast mounted articulator. So pretend it's not a cast. Pretend it's your patient and they're just closing in MIP. So this is a picture of somebody that just has their teeth closed together, right? And then we'll ask them, hey, slide your jaw forward so that you're in an edge-to-edge position. So you can't really see it there, but the number 9 is in contact with the lower tooth. So they're in an edge-to-edge position. Okay? So you've done that in the patient's mouth. And what do you notice about the posterior teeth there? You got space. Okay? So what we're going to do is, remember that bite wedge that we had? So we're going to squirt some in the back and say, hold your teeth in that edge-to-edge position, and we'll let that polymerize or set. Okay? So now we got a bite registration or a jaw relation record of the patient when they are in an edge-to-edge position. So what I'll do is I'll start passing this around, but I have a video, and you guys can simulate what it does in the video about what we do with this record now that we are on the articulator. Okay? So what you can start doing is just start moving these guys up and down. Okay? So just going to hold it together. Okay, with me so far? All right, edge-to-edge position. We got space in the back. We'll squirt some material in there. Now what you'll do is, now we've moved away from the patient's mouth. Now we got this set up on our articulator. So we get molds of the patient, okay, mounted on the articulator. We'll unlatch the hinge. So if you unlatch the hinge, you can get them in that edge-to-edge position. So you can move the equivalent of moving the lower teeth forward, and then you put the bite records in. And then in this articulator, instead of, it just looks a little different, but this here, as you rotate that, that changes the condylar inclination. We're passing around that articulator around so you guys can kind of see, right now this is very steep. So the point is you're going to alter or toggle the inclination here until the teeth fully seat into the bite record. So we're going from steep to shallow, and you can see as we go through that range, there's going to be an inclination or an angle at which it's the most stable. And once you find that angle, and sometimes it's a little subtle, it's, there may be a little bit of a range, then you want to lock that in place, and that becomes your condylar inclination. Okay? Does that make sense? Okay. So the angle that you toggle it to, when those teeth are fully seated in, then we can assume that that is the patient's condylar inclination. So I will say on these articulators that you guys have, your Whitmix 2240s, it's a little harder to do. But that's sort of the principle. Okay? So if you really wanted to, you can program the articulator to the patient's exact, or you can program it a little closer to what the patient kind of has. As an average, usually we won't do this procedure. What we've done is we've accepted sort of an anatomical average, somewhere between 25 and 30 degrees. And then, because this is kind of time-consuming, not many kind of cases or dentists will go through this trouble to do it. Okay.
What would we do if the patient doesn't have their front teeth, so they don't have anything to touch?
Yeah, the whole point is that you want them in some protrusive kind of movement. So at some point, hopefully they touch somewhere. What we'll learn in maybe your RPD in your denture class is if, let's say, they're missing a lot of teeth, so you can make a little wax plate, basically, and then put that in the mouth. So where there's wax, you simulate, I just think of wax, the pink stuff, as their teeth. So you have some sort of substitute to help you make these records. Okay? So it's not necessarily the incisors need to be edge to edge, okay, but you need them in some protrusive position. Okay, so let's talk about the arc of closure / movement. So remember we talked about the distance from the hinge to, let's say, your teeth. That is important because it affects, where our teeth move as we go in protrusive or we go in lateral. Right, in lateral, one condyle rotates, the other translates. Okay, so we have this cast mounted on an articulator, and we'll say that this is close to the anatomical kind of average, or it represents the anatomy of the patient. Right, so that distance is representative of what the patient has in their head. So our arc of closure or movement would then follow that arc. Now we have the same setup, except now we have it in a triple tray. So I know you guys haven't seen triple trays yet, but you guys have made them. So imagine, remember we said it captures three things: the opposing arch. That's number one. Number two is the prepped arch, which includes the prep and the adjacent teeth. And number three is you have the jaw relation record. But look at where the hinge is. So the hinge is not in sort of a representative of the patient's anatomy. It's much different, right? So that is the arc of closure or movement on a triple tray. So if you overlay them together, we'll notice that at the point of contact, MIP position, remember I had my hand straight out, so whether I rotate around my shoulder or my elbow, my starting position is the same. You see where the lines intersect. But any movement away from that, you'll find that they take a different path. Okay, so let me show you the significance of that. And I think the significance of that is more easily seen in lateral movements. So this is just sort of a, from the side, a sagittal, right? But just opening and closing. But the same principle applies as you rotate. So if you think about it, as I rotate here, or if I rotate here, the principle still applies. So if I move my hand this way, or my arm, it follows a different path, here to here versus here to here, as well as from here to here and here to here. Okay? So I'll show you a couple videos of how. So we'll start with the one mounted in the correct position. So as we go in lateral movements, both working and non-working, what we'll show you is the
Or not zoom in, but just focus. Make sure that's focus.
right there. So you can see the little arrow, right? No. Okay, the next slide will have the picture a little bit more clearly. So let's see. So as you go into those movements, see the picture on the right side? So I've drawn it a little deeper in pencil, but that's the movement. So the cusp that is marking this is your, this is in the central fossa, so it's your distal lingual cusp of the maxillary molar. So this is what we're tracking. So in working and non-working movements, you get this path that cusp follows. So we'll say that this is kind of what the patient is actually doing in their mouth, right? Then we go to a triple tray, and let's see how that moves in a working and non-working movement. Okay. So we know that it's a different hinge position. So you can see the difference in the path of movement, right? So if it follows a different path, or what's the next step after we mount this case up? What do we have to do? Wax up. We got to wax up the crown to make it look like a tooth. And then how do we know how to design the contours of this crown? Well, one of the things that we want is mutually protected occlusion, or we want to avoid balancing interferences, right? So that it'd be valuable to know the path in which that opposing cusp moves in our lateral movements, right? So if we know the path of that cusp as we go in these movements, right? So as you move your jaw to the non-working side, so the opposite side, that distal lingual cusp, or the maximolar, passes through the buccal cusp of your mandibular tooth, right? So if you want to design our mandibular tooth to kind of allow for that cusp to pass through, well, we want to know exactly where that cusp is going to go. Okay. So you can see that if we use a triple tray, the information in movements doesn't seem to be as accurate. Okay. So that's one of the disadvantages of using the triple tray, is that we are no longer moving in a anatomically representative motion, but rather we're just kind of picking an arbitrary kind of hinge point and then rotating around that. So therefore, the cusp movement, or the path in which it goes, isn't representative, and thus if you made a crown and wax up, you couldn't really accurately test whether that is in balancing interference or in any interference, because when you make it on the triple tray, it doesn't really simulate what the mouth does. So you may have a situation where you've designed a crown on a triple tray, and on the triple tray you test it, you go in all the movements, and you think, oh, great, everything looks good, I have no interferences. And then you go put it in the patient's mouth, and then you'll find, oh, it's hitting somewhere I don't want it to hit, because now that upper tooth actually follows the path on the right. Are we good with that? So why would you be less concerned about possible interferences if the patient has canine guidance versus group function? Who wants to take a stab at that? Oscar. Okay, so you're referring to what scheme? Canine guidance, I'm assuming, right? So in canine guidance, as you move to the side, the idea is that you have space between the posterior teeth. So if you have space between your posterior teeth, then it's less likely for your crown that you've designed to be in an interference, okay? So it gives us some room for error. Right? So the more disclusion and the greater the space that you have, the less critical or the less chance you'll have for one of these balancing interferences. Whereas group function, the idea is that multiple teeth are in contact. So maybe before you prep the crown, that molar was actually in group function. Now you got to design this crown so that's in harmony with the other teeth when that lower jaw moves in group function. Okay? So here's maybe a trickier question. Okay, so let's say you didn't know the amount of, how should I phrase this? Let's say you didn't take a protrusive record, and then you weren't sure about the patient's condylar inclination, right? And then you want to set the articulator such that you minimize the chance of error there. So we're going to arbitrarily pick an inclination, okay? So in order to kind of be on the safer side, would you rather set the inclination closer, steeper, or more shallow in order to give you the best chance for avoiding an interference? More shallow. And why do you say more shallow?
Well, if it's steeper, you're going to get disclusion quicker, and so the possible interference will be less likely. But if it was steeper, if it was more shallow, then possible interference is going to be more likely. And so then if you can make sure that there's going to be no interference on a shallow eminence, then what?
No, you're doing great.
Then in the patient's mouth, if you err towards shallow in the patient's mouth, hopefully they're a little bit more steep than that, and then you'll be good. There won't be interference.
Okay, so if you didn't catch that, that'll be replayed on Echo 360. I think that's right, yeah. So it's a lot of words, but so go back and listen to that if you didn't explain. I'll try to kind of explain it one more time, but the principle is correct. If you set it more shallow, right, and it's one of the things you kind of have to kind of visualize and think about. So if you don't get it right away, that's okay, but it's important to kind of understand why. So if it takes you a little bit longer, you can either ask me or AJ. We'll do a great job explaining it to you. But if you want to overcompensate, because remember, the more steep your inclination is, what do we say about the amount of space in the posterior? You have more or less? More, right? And then the more shallow it is, you have less space, right? So let's say your patient is average, 30, okay? And then you set on your articulator, we said, okay, it's better to set it more shallow. We overcompensate. We'll say it's 0, okay? So now on your articulator, when you move the jaw to the side-to-side motions, we have less separation in the posterior. So we're going to design our crown so that, it'll clear the other teeth even when the inclination is at 0, okay, where there's less space in the back. Now, you take that same crown and you put it in the patient's mouth. Well, they're actually at 30. So we know at 30, they actually have more space in the back, right? Because we said, okay, as you steepen the inclination, you get more space. So in reality, you got more space there than where you had designed the crown to. Okay? So if you want to think of it the verse way, so let's say our patient's 30. Okay. So on your articulator, you get everything mounted up, and then you mistakenly set the inclination to 60. Okay. So you're at 60 now. Now, when you move to the side or in protrusion, you got a ton of space for clearance, right? So let's say you make those cusp tips really high because you think, oh, I got plenty of space to clear it. So I take that same crown, I'll put it in the patient's mouth, and in reality, they're at 30, so when they move to the side, the space that you thought was there wasn't actually there. Now you're hitting. Okay? So think about that. If you don't get it today, that's fine. But eventually, at some point, it'd be good to understand. So what information is lost when using a triple tray? Who wants to take a guess? Or do I have it on the next slide already? Okay. So our guidance in non-working. Okay, let's start with the second one because that's the most obvious. We've talked about this already. The relationship between the teeth and the hinge axis, right? So think of the distance from my shoulder to my fingertip. That information is not accurate. And we see the effects of that. So if your arc of movement is different, then when we check these things in protrusion and lateral obtrusive movements, it doesn't represent the mouth, so we can't design the crown as accurately. Now, in the case of canine guidance, there's a little bit more room fudge factor, so a lot of times we're okay with not having the actual correct hinge axis. Okay? Let's also look at it this way. The triple tray, we've only captured one arch, or one quadrant, two quadrants, upper and lower quadrant. So only half of the mouth, right? So as I move my jaw, let's say I'm moving in my working movement. So let's say I've gotten a triple tray impression of my right side. I'm doing a crown at number 30. All right? And I got canine guidance on both sides. So as I move my jaw to the right canines are in my triple tray impression. Okay? So I have that information kind of. At least the teeth are there, so it's kind of guiding, even though it's a different arc of movement, but at least the teeth are there. But let's talk about your non-working movement when you go the opposite way. Sorry, did I get that backwards? That way and that way. Okay. The idea is that you have no teeth on the opposite side to really simulate that canine guidance. So if you had canine guidance on the opposite side, well, it's not reflected in your stone cast here because it's not even present, right? So you'll lose that information when you use a triple tray. Okay? So in our clinic, we have certain guidelines as to when we can use a triple tray. And I'll pull those up real quick for us. See if I have it somewhere. But one of them is going to be this idea of mutually protected occlusion or canine guidance. Remember, we said in canine guidance, even if our the canine guidance kind of gives us a little bit more room for error because we got space in the back, that would minimize the chance for interference. So contraindication, multiple fixed units. So triple trays are good for kind of straightforward single unit cases. The minute you got multiple teeth that you're making an impression of, we prefer or we require you to use a full arch so we have all the information. A fixed partial denture, so that's a bridge, basically, that implies multiple units. Survey crowns, right? Everybody remember what a survey crown is? Crown that fits onto a partial denture. Implant-supported restoration, so you haven't kind of learned about yet. And then no cases with class 2 or class 3 occlusion. Okay, so it's got to be a straightforward class 1, kind of the occlusion's kind of normal, you're doing a single crown. And then the indication for angle class 1 occlusion, mutually protected occlusion, bounded by intact teeth. And we don't want to have, we shouldn't use the triple tray for the most posterior tooth in the mouth. Okay? Because the theory is that if you use a triple tray, if it's the most posterior tooth, you have a chance to have some tipping or there's a rocking there, Okay, whereas if you have teeth on both sides, then that's a little bit more stable. So the most posterior tooth, generally, the theories will have a little bit more error because it's not stabilized by teeth on both sides. So those are things that we require in our clinic. In reality, many dentists use triple trays, and we'll get into the reasons for that right now, I guess. So what are the advantages of using a triple tray? Okay, well, obviously it's a lot less impression material, so you're getting 2 arches in one, so there's no need for a separate impression. So even at school costs, one of those cartridges is $10, right? So you can imagine if you're doing a full arch, you're essentially doubling the amount of impression material. You got a busy practice, that adds up pretty significantly over time. Time is also money. The quicker you can get through these procedures, the more patients you can see. So it does save a lot of time in that sense, where you don't have to do a separate opposing arch. And then the jaw relationship is captured with the PDL and compression. So if you think about it, if you took 2 static impressions, upper and lower, and then you hand articulated them, right, the stone doesn't give, but when you bite together, your PDL compresses a little bit, right? So we've mounted those casts in sort of, you can think of it as a static, or the PDLs are in a static relationship. Whereas when you take a triple tray impression, you squirt around and then you have a triple tray and tell them to bite down. Well, in that jaw relation record that you've captured, the PDLs have been loaded and they're compressed. So in theory, if you want to design the crown where when they're touching, you got less occlusal adjustments, there may be a small advantage in taking a triple tray because the PDLs are kind of already compressed. Let's take a break. 10 minutes. All right, so we got, let me pull this up. Politics and Politics, September 9th, 2016, Fairmont Princess Hotel. We got a debate between ASDO and Midwestern, including live patient licensure exam, mid-level providers. Why is it more money if you just want to attend the social? What's that? So why don't you just pay $5 and then not go to the debate? Oh, very clever. Very clever. And who's standing by the door? Okay. Okay, let's finish this up. We're kind of winding down. There's only kind of one last... Oh. Let's do this. So the articulators you guys have, we'll call that a semi-adjustable articulator. You see all the little knobs? So let's figure out what each of these knobs do. So you've got the 2 black ones on top. What does that allow us to do? Adjust our condylar inclination. How about on our condylar inclination, those parts, you got another knob, silver knobs, right? What does that do for us? Do you guys remember the term immediate side shift? Right? So your condyles, in theory, some people believe that you can just move it to the side, laterally. Right? So there's different, you can adjust the amount of immediate side shift by unscrewing those and sliding that bar. So if you look at the underside of it, the condyle hits the inner wall, but if you give yourself more room and you allow for some immediate side shift, it has room to kind of move to the side before it hits the medial walls. Okay? So that's another thing you can adjust. Some things you can't adjust that you could adjust on a fully adjustable articulator is our intercondylar distance. Right? So if you think about it this way, right, you have varying distances between the condyle. Right? You can have short distance or long distance. as you rotate, right, it rotates around a condyle, so the length between the condyle has an impact as well. Remember, just like how close we are to the hinge, the length, the distance between the teeth and the hinge play a role in lateral movements. Well, the same principle applies with our intercondylar distance. So some articulators allow you to kind of make a measurement, and then you can adjust the intercondylar distance. With a non-adjustable, okay, so we got a non-adjustable, which is, think of it as a triple tray. You can even have one of those mini kind of hinge, just a small, think of it the size of a triple tray, but just a full arch. Again, all that does is just go up and down, clack, 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 right? No other knobs to go by. So we'll call that a non-adjustable. The semi-adjustable is what we have. And then really the most significant things for the fully adjustable, I guess for the purposes of this level of education, we'll say, or maybe just for the purpose of the test, we'll say you can't change the intercondylar distance. There's a ton more things you can do with a fully adjustable, but it's way beyond the scope of this class. If you guys are really interested, we can do a little lunch and learn that, kind of dive into these more complex stuff. Question? Nope, just we can write them down as I say them, or somebody can type up a slide and send it out. Question? No, you can. Yeah, so that's something that you can't do on yours, which is a semi-adjustable. The fully adjustable, you can. Okay. All right, so let's finish up in the boards. I bring this up because it's in your Mosby's kind of board review, and sometimes they'll ask about it. But this idea of Archon and non-Archon articulators. You guys remember that from first year? So what is Archon? What's the difference between Archon versus non-Archon? Okay, so let's think of it this way. Just remember, Archon articulator is built like your mouth is. So if you were to take your articulator apart, so do you know how to take the articulator apart? So you unlatch the hinge, and then there's two rubber things on the side. So you remove those, and then you can separate the top member from the bottom member. Okay. So anatomically, what part, maxilla or mandible, so either maxilla or mandible, where is your condyle located? In which arch? Mandible, sure? Oh boy. Lord have mercy. Okay, condyle is located on your mandible. So if you took these apart, where is the condyle? On the upper or lower member of your articulator? Lower. So this simulates your mouth or your head. So remember that as a Archon articulator. Okay? Whereas, and I got one that I can pass around. And you can put this back together. I don't know how it goes back, but we'll figure it out. They also design a different type of articulator where it's the reverse, where your condyle, and you can't take this one apart, but you'll see that the lower, okay, so let's also put it this way. The upper member is where your kind of fossa, or what simulates your fossa, is located, right? So when you take this apart, these little metal pieces represent your glenoid fossa and then your articular eminence, right? So that's anatomically correct as well. With this, your fossa, or where your condylar inclination can be adjusted, is actually attached to the lower member of the articulator, which is not correct. And if you were able to take this apart, you would find that the condyle is actually connected to the upper member of the articulator. So it's reverse of what you have anatomically. So we'll pass that around. So Archon versus non-Archon. Okay? And then this is a series of photos that kind of explain what's the significance. Who cares if it's on the upper or lower question?
So is non-archon on the maxilla basically not attached to the mandible, right? But would be considered the mandible.
Let's rephrase that question. I don't quite understand.
Archon, the mandible, the condyles are on the lower part.
Right. So that's similar to what you have in your head.
Non-archon, where are the condyles?
It's reversed. Yes.
So it's
Yeah.
on the
Yep.
maxilla.
Yep. Okay. Yeah. Okay. So this is a picture of a Archon articulator. So this is similar to what you have. So your Whitmix 2240s, the one you have with you, this is a Archon articulator. This picture here is also an Archon articulator. And you can kind of see it working too by opening and closing yours. But the idea is, as you open and close, right? Let's look at the condylar inclination relative to that Frankfurt horizontal. Okay? So we'll say, okay, when we start off, it's at 30 degrees. Okay, that's a pretty simple measurement, right? We've set it at 30 degrees. As you open the articulator, it's still at 30 degrees if you were to draw the two lines and connect it. So open and close your articulator, and you see how the inclination remains the same relative to the Frankfurt horizontal. Okay. So let's go to a non-Archon articulator, and let's do the same thing. Open, close, open, close. Okay. So it starts off at 30, similar to the Archon one. And now when we open it, what happens? Well, the condylar inclination just stays there. It doesn't move with the upper member of the articulator. So as you, where's this guy at? So it's getting passed around. Go ahead. And as you open and close, notice the difference between the two. Okay. So the idea is, as you open the pin on a non-Archon articulator, your condylar inclination changes. Okay. So that's not as ideal, because we know our condylar inclination doesn't change in our head. So if we want to open or close the pin or move that, we want that condylar inclination to kind of remain the same at where we set it at, right? Okay, because we know the condylar inclination has an effect on the distance between the posterior teeth in mandibular movements. Okay. So let's paint this scenario. Okay. Let's just define it first. In an Archon articulator, as you open the pin, so this is equivalent of increasing. I should probably write that. As you open the pin, it's the equivalent of increasing vertical dimension. The condylar inclination stays the same relative to the Frankfurt horizontal plane. Okay, so let's paint this example. Let's say you have a patient came in and looked like this, so all the teeth in their mouth. Okay, let's say they had tetracycline staining, and they just want new crowns, and they want just white teeth. Okay, so you go ahead and you prep all the teeth. I just kind of ground the stone there. Okay, so now we've prepared it for crowns. So let's take a step back and remember this concept of vertical dimension of occlusion. So one way to think about it is, okay, let's say we measured the distance from the freegingival margin of the canine to canine. That's some distance, right? Then we prepared the teeth, and then we mounted it at the same vertical dimension that the patient had prior. So if we measure the freegingival margin from canine to canine, we would have the same distance. So that means that if we were to make crowns based on the way this is mounted, we have not changed the vertical dimension of occlusion. You guys with me? Okay. So based on this, we haven't changed the vertical dimension of occlusion, right? Because the distance between the jaws are still the same. Okay. So let's move on, and let's just say, hypothetically, and we can pick any reason we want, let's say we want to, in this stage, increase the patient's vertical dimension of occlusion. So what that means is we want to make the crowns a little taller than what they used to be before they were prepped. Okay? So we'll open the pin a little bit, right? So now if we make crowns to this relationship, crowns will be longer, and if we measured from free gingival margin to free gingival margin, that dimension is larger than what we started with. So that, in a sense, has increased our vertical dimension of occlusion after we've made crowns to this mounting. Okay? So the reason I bring up this example is because, remember, as we compared Archon to non-Archon, we know that as we raise the pin in a Archon articulator, that condylar inclination stays the same. So that information is preserved. Whereas if you did this same setup, or the same kind of exercise in a non-Archon articulator, and you open the pin, well, you've thus changed the condylar inclination. And we know you want to keep that condylar inclination as close to what the patient has in their head as possible. Okay? So that's the principle of why Archon versus non-Archon matters. It matters in situations where you have opened the pin or you've increased the vertical dimension, because when you open the pin, the condylar inclination stays the same in an Archon articulator, but it changes when you're in a non-Archon articulator. Questions on that? Enough about articulators?
So I get that if you increase vertical dimension and all that, I can just memorize that, Archon versus non-Archon,
Yes.
that it changes if it's non-Archon, but I don't, visually, I'm watching the hinge, and they both look like they're opening and doing the same thing. I don't see a degree change. So
Okay.
I can't.
So if you were to take a line, this is one line,
Yeah.
and then the other line is this, right? So pick a number. What do you say that angle is?
Yeah, 30.
30. As I go like this, and we draw the two same lines, what angle is that?
Yeah.
30.
The metal one, the other.
Yeah, 30, right? So as you move down, pretend you're going to straight protrusive movement, relative to this horizon, what angle is your condyle moving down at?
Oh,
30.
So it maintains the eminence.
Right.
And
Whereas-
the other one has no eminence, or
Well,
it has one, but the eminence moves. Yeah, okay.
so in that same example, if this is an Archon, and we opened it, right, the angle between your horizontal versus that line is now different. It's greater. We'll say maybe 45. Yeah. So now in that non-Archon articulator, as you go in a protrusive movement, well, it's moving at a 45-degree angle instead of what you intended, which is a 30-degree angle.
Yeah,
Okay. So that's the disadvantage of using a non-Archon articulator when you're altering vertical dimension, right, or opening the pin. Or, sorry, when you're altering vertical dimension. So it can go in either direction. So whether you increase or decrease, if you've changed the vertical dimension or basically changed the pin, you have not maintained that condylar inclination in a non-Archon articulator. Okay, question? Yeah. Correct. So if you made a CEREC crown, right? So AG is saying, in CEREC, we never take a face bow. We don't, we can't relate it to the jaw. There is a function in CEREC where you can set a condylar inclination. So you can, essentially you can think of it as a fake bow. You fake the face bow. You just put it in the center of the articulator, okay? So that part, the arc of movement may not be entirely correct, but they'll say, well, we're close enough. And then with that virtual articulator, you can adjust for the condylar inclination. You can kind of pick it however you choose. Okay, but you're right in the sense that the disadvantage or the limitation of a CAD/CAM system is that you can't, at this point right now, do a virtual face bow, or it's very challenging to kind of, yeah, there's a way, but it's like you need a 3D cone beam scan and all that. It's just way too expensive for kind of normal everyday use. So, which means that if you have a crown, whether it's designed on CEREC or on a triple tray, or just on a non-adjustable articulator that doesn't simulate what the patient does, the thing you got to watch out for is not so much contact and MIP, because that's going to be the same. Remember, it doesn't matter what the length of that arc is, because we always start in the same spot, but it's upon movements in your lateral motions is where you need to be really careful in checking before you cement the crown, okay? So it's your excursive movements that could be compromised in a situation where you haven't done this, okay? So at some point, there's a cost benefit, right? The theory is if you don't do all this sophisticated mounting and all that, your crown design may not be as accurate as it needs to be for no adjustments. But you got to think about, okay, well, if I need to do a little adjustment, yeah, it just takes a few seconds to zip, 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 and it's adjusted. So is that little bit of potential adjustment, okay, are you okay doing that with the benefit of, oh, you can save time and impression material, and the ease of that by using a triple tray, right? So if you can live with the fact that, hey, I can do a few adjustments and then it'll be correct, then in those situations, you're more likely to use a triple tray. But if you're doing a real complex case, let's say a full mouth like this, right, and, instead of adjusting one crown, you got to adjust 16, then you may want to opt for something a little bit more sophisticated to minimize the amount of adjustment you have to do when you deliver the final crowns. Question? No? Does that make sense? Okay. I think that's all I got for our... I know some of you may not get this right away. This is what I'll do. I'll come in tomorrow. Tomorrow is my day off. I'll spend a lunch with those that need a little extra tutoring for this. Okay? So what room do you guys want to be in? Here? Okay. So we'll come here. I'll be at noon. Come on my day off because I want you to learn this stuff. The problem I have is used to be an engineer, so it's like, love this stuff. So, but I will say this. If you understand this lecture, you will know more about mandibular movement and articulators more than anybody currently at this, students at this school. I think we're very kind of weak at this point. All right. So before we go, you guys want to do the quiz review or the exam? Okay. Let me turn this off.